Okay, in this chapter, we're going to talk about the delivery of mental health care. Um, we know a lot about the history of medical health care, but it's important to look at the history of mental health care because it affects a lot of our perceptions today, some of the stigmas that we've already talked about. And like we've discussed, this population was marginalized and mistreated in a lot of instances throughout history by different cultural groups. So in 400 BC, Hippocrates stated that mental illness is a result of disturbed physiology and should be treated as a medical illness. So even back then, there was an individual that recognized that mental health was part of our physical health, of holistic health. So, pretty progressive guy there. At the time, they were treating things with humoral theory, which was basically that disease was caused by an imbalance of the humors. So, even though he recognized that mental illness was also a medical illness, they really weren't on the cutting edge of treating those types of things. So they would do bleeding, like cutting, or leeches, inducing vomiting, purging with laxatives. So, um, you know, this was done clear up into the 19th century, where if nothing else worked, then just try this. In the 16th century, as far as mental health treatment was concerned, the mentally ill were isolated with vagrants and delinquents. So remember when we talked about in fundamentals, those pest houses where groups of people were put together, disease was rampant, inhumane treatment was worse than you could possibly imagine. They'd be chained, kept essentially in dungeons. The cultural base of this age saw mentally ill as a demon possession, as somebody that should be shunned. So essentially, if someone was determined to have a mental illness, they were locked away, they were mistreated, and not cared for by their families at all. In the 17th century, society became more of a rural and agricultural type of shift. So, mental illness became more of a familial, quote unquote, problem. So, no medical treatment is sought. People that had mental illness were cared for in the home. Um, Definition of insanity is more theoretical based on that family or community's beliefs, as in, that family has the son that quote unquote isn't quite right, or that type of thing. Families would consult faith healers or a member of the clergy. Treatment with herbs or different things like that were commonplace. Um, the community would watch out for the mentally disabled. And then some religious orders begin caring for mental illness at this time. So, particularly, the nuns of the Roman Catholic Church, kind of the same progression as we saw with medical treatment, as it became more of a family type issue with support from religious sects. In the 18th century, institutionalization first appeared in the 1700s, based on the fact that society had a responsibility to the poor and mentally ill. So, um, society as a whole recognized that there needed to be some sort of humane treatment, some sort of support for these certain marginalized populations. So the population was moving into more centralized areas. So you got to think about the Industrial Revolution and what was occurring in history. So people were starting to live in cities in larger numbers for the first time. And so even though the numbers didn't change, it appeared like there were more sick people because they were centralized into population centers. So they were recognizing, hey, we got all of these sick people, both medically and mentally. We've got to do something. Also, with the Industrial Revolution, more family members were going to work than ever before. So, mom, dad, and even the kids all had jobs that they were going to. So, there wasn't someone at home to take care of, the infirm or the mentally ill as the family had done before. So without that oversight, there are very few medical treatments available. There was definitely a public safety issue. There were welfare institutions and poorhouses that catered to the poor, not like the pest houses before. So they definitely progressive movement towards more humane treatment. And at this point, the theory was kind of suggested that moral treatment could affect mental health or mental illness in person's psychology and change their behavior. So this is really the first time we thought about psychological treatment, about group therapy, about discussing uh, things with people that had mental illness in an attempt to improve their psychology and behavior. So, with this, institutionalization became the development of asylums. So, if a family wasn't able to take care of an individual, or somebody was poor, asylums house the insane, as well as prisoners and orphans. So, in these institutions, typically people had no rights and still endured some cruel and inhumane treatment. So it changed a little bit from the, just chained in the dungeon. Inhumane treatments were a lot of times uh, conducted upon individuals under the guise of treatment for their mental illness. So we started doing things like psychotherapy with like shock treatments and lobotomies and all of these different things at this time, where we thought that um, perhaps they were helping these individuals, but it was indeed quite cruel. And because mentally ill individuals were housed alongside prisoners, there was no differentiation between, what was a good but ill person or a person that had, violated some sort of societal code and perhaps was a very bad person. So they were treated the same within these asylums. Bedlam, which was Bethlehem Hospital in England, was an early example of this. It's kind of one of the notorious asylums from this time. And there were even guided tours in its heyday, so people could pay to go see the insane being chained or acting out. If somebody was in a room, having a real excited action or something like that, people would come to see it. So, not really great treatment of these individuals. So there were definitely some better facilities for individuals that were wealthy that could pay for it. But of course, given the time period, these were definitely racially exclusive. So typically for white families that were wealthy and could pay to have their loved ones taken care of in a better situation. Into the 19th century, we really started honing psychiatry. So Benjamin Rush is credited with being the first psychiatrist. In the early 19th century, he started a movement to improve care in these asylums. He felt that with better treatment, they would become what he described as normal functioning individuals. So, you know, we know now the definition of normal can be several different shades of gray, but his initial theory and purpose was to improve treatment of the mentally ill in hopes for rehabilitation. So the role of psychiatry truly began to evolve at this point. He was a surgeon first, so this was his specialty after surgery. As you can imagine, a lot of his intervention and study was into um, surgical procedure that could be done in addition to other, evolving psychiatric treatments for the cure of mental illness. So he thought that insanity was due to either a lesion on the brain or a moral cause. So either there was some kind of organic cause for this to be happening that could either be repaired surgically or it couldn't, or if it was a moral cause or defined as moral insanity, it was due to willful violation of natural laws. So, yeah, acting out immorally or being a victim of improper living condition or even stresses. So, even though he was defining these things as a moral issue, he was recognizing that there were environmental factors, including stresses, that could be triggering or causing some of the issues. So a lot of his treatments were focused on what was deemed at the time as immoral behavior, like masturbation, alcohol use, excessive ambition, wanting too much, or jealousy, even. So, still, you have to consider in the time period um, where he was kind of coming from as far as his theory and approach. In the 19th century as well, we see the emergence of Dorothea Dix. So she did a lot to help, especially the poor population. So she was originally a school teacher, and essentially was kind of a definitely in the cutting edge for her time, especially being a woman, but was a whistleblower of sorts who worked towards establishing standards of care. She, in the time that she worked, established 32 state hospitals for the care of mentally ill, infirm, and poor populations. Um, she was also helpful in developing training programs for nurses. Um, Before, an option for caring for the insane was not seen as a fit occupation for women. So, in these asylums, up until this point, it was male orderlies and those types of individuals that were caring for these people because they were deemed dangerous, and that was just not a place for a lady. But this is where nursing really enters the scene, where we start training. Uh, and at this point, you got to realize that nursing is very, almost exclusively a female occupation. So they start training women to care for individuals with mental health illnesses and recognizing the medical link to it. In addition to Dorothea Dix, Linda Richards was a pioneer, being the first trained nurse in America. She traveled to London for more training at St. Thomas Hospital, which was established by Florence Nightingale. We talked about that in Fundamentals of Nursing. Upon completion of her training and return to America, Richard opens the Boston City Hospital. Training school for nurses, and in 1913, the first psychiatric content was added or included in the curriculum of the school. So Dorothea Dix was pushing for it. Even in the late 19th century, which would have been the late 1900s when Linda Richards was just born, but eventually it started being integrated into the curriculum of all nursing schools. It was also at this time in the 19th century that Freud began um, talking about his views on psychoanalysts and the things that we discussed in chapter 3. So it was called the era of the talking cure, where we actually had psychiatry developing even beyond the surgical approach of others. Most patients could be talked to regarding past events, how to proceed. So they started realizing that there were some differentiations in the levels of mental illness. So recognizing that counseling and supportive therapy were appropriate for some, but the psychotic were definitely still institutionalized at this point. In 1908, Clifford Beers was admitted to a mental institute and later discharged. He wrote the autobiography, A Mind That Found Itself, which describes his treatment. So, a very interesting perspective from a person that was placed into one of these asylums and ultimately wrote a story about his experience there and his process of what he believes was his rehabilitation. So he describes a lot of maltreatment, mistreatment. He was certainly a cognizant person that knew what was going on and what was happening to him. He was committed somewhat against his will. And then his story actually brought a lot more publicity to mental illness, the treatment of individuals that are placed in these asylums, and began at least a slow change in the system of care. The National Mental Health Association was eventually formed, which developed criteria and care um, treatment standards. Moving into the 20th century, we see the passing of the National Mental Health Care Act of 1946. It provided funds for research, it provided funds to advanced nursing degrees, improved community service for individual community service and outreach for individuals with mental illness. However, in the 1950s, we see an advent of new medications that made caring for the mentally ill easier outside of a facility. And so we saw a shift back into care by the family, a movement to deinstitutionalize. Um, so things have definitely waxed and waned over the last couple hundred years. So at this point, they determine that they can medicate people enough that they can be cared for in the home, in society. And so, this is good in theory, but where has it put us now? This shift in the 1950s probably wasn't the biggest impact on mental health. It was actually in the 80s when we saw a big shift out of state hospitals and mental institutions, closing of a lot of state hospitals due to funding and that kind of thing, that we really saw a deinstitutionalization. So we do largely now have an issue with access that I think you could say started in the 50s and definitely came to a boiling point in the 80s. And so, that's where we talk about, where can you get help, the shortage of beds when somebody does need admitted to a facility, and all of these different things. So, a lot of this stuff is just going to be a review, but it's kind of looking at it through the prism of mental health. So, many decisions made by healthcare professionals involve legal and ethical issues. We've talked about that at length. That applies the same, if not more, to patient suffering with mental illness. Certainly, if somebody does not have the capacity to make decisions or the ability to care for oneself, we always have to make sure that we are acting in an ethical manner, that we are advocating for our patients and keeping their rights and individual, autonomy first and foremost in mind. Nurses definitely have to be familiar with institutional policy as far as, escalating complaints, like I said, advocating for the patient. So very, very important. This is the patient's Bill of Rights. You've seen this before. This is put out by the ANA, and then it was kind of, I guess you could say, tweaked or looked at again from the lens of mental health in the 1980s, when we see the mental health system Bill of Rights being released. Patients are given the right to read these at the time of admissions. Nurses should know what patient rights are and ensure that they are preserved. That's where we come in as the advocate for our patients. We've talked about informed consent before and how important it is that patients know what treatment they're receiving, and that they're given all of the pros and cons, the benefits and risks, and that they're able to make a decision regarding that treatment. However, a lot of times in mental health admissions, the patient may not be of sound mind, but they should definitely be assessed by a psychiatrist to determine if they're able to make their own decisions. If they are not, then that individual can be deemed incompetent. So if they are not able to make their informed decisions about healthcare, another person, a family member, can do so. We've talked about durable power of attorney, and how that healthcare designee can make decisions for the individual. If a person is of sound mind, they do have the right to refuse any treatment at any time. Confidentiality should be maintained in all healthcare situations. That includes treatment of mental illness. So make sure that HIPAA is always first and foremost in your mind, and that you're protecting your patient's information. In the event that somebody is involuntarily admitted to a facility, it means that the patient is essentially being admitted against their will, or at least that they're not able to give consent for the admission. The amount of time is determined by the court. Uh, this is where we have to have a statement from a psychiatrist or psychologist determining that the patient's mental state puts them at danger for their self of others, and that they're incapable or incompetent in making a decision regarding their own safety. So people can be detained on an emergency status against their will for about 48 to 72 hours, and then they must be discharged or given voluntary status for admission. They have a right for a court hearing to determine if there is a need for continuation of involuntary treatment. So these holds can be done when we feel like somebody is a risk for themselves. If somebody threatens suicide, we can put them on a hold. But they do need to be evaluated within that time period, because we can't hold them indefinitely. We need a professional to determine if with their state of mind, if they truly are competent to make decisions. People also are admitted to psychiatric units voluntarily. So they choose to comply with the treatment program. The doctor will write an order for admission, and the client signs and agrees to the terms of treatment. The client will then be allowed to sign appropriate documents and leave when treatment is completed, usually after 48 to 72 hours. The doctor can assess the situation. If during that 48 to 72-hour time period the patient decides that okay, wait, nope, I don't want to be here, I am going to leave, they will be asked to sign out AMA, because at the point that they determine that they are in need of help and they're being treated by a physician, until that physician releases them, and then it's just like with any medical condition. If you were treating a patient with pneumonia and all of a sudden they decided they were going to quit, they didn't want their antibiotics anymore, and they were going to leave the hospital, same thing. They would have to sign out AMA. There's a lot of mental health components, mental illness components in correctional facility nursing. A lot of different pathologies. I mean, you could go into the discussion about what causes a person to commit crime. In the first place. So sometimes it's simply a means of survival, especially with things like theft and that kind of thing. But for other people, it is a compulsion that could be driven by a mental health issue, especially with serious crimes like rape, murder, those types of things. You could definitely have a discussion about what mental illness might be present to cause a person to do that. The biggest problem with nursing in correctional facility type situation is manipulation. So a lot of sociopathic type behavior with some of these individuals, especially if they're skilled at deceit or devious thinking, uh, being coercive, those types of things. Corrective facilities are focused on rehabilitation. So, they will have on staff different psychiatric um, personnel to assist and hopefully rehabilitate individuals. That is the point of being in prison. That if depending on their sentence, they're able to return to society again as a rehabilitated individual. All prisoners take a psychiatric evaluation upon admittance into a federal level prison. The process is required by the American Correctional Association. When the inmate arrives, they may ask about previous counseling, family histories, history of seizure or suicide attempt that could indicate an organic type issue or a history of mental illness. They ask about criminal history, what things have you done, drug use, abuse, that kind of thing. Further diagnostic evaluation is recommended and referral is warranted if the inmate demonstrates symptoms or behaviors of psychiatric illness. So, if they are deemed to have a mental illness, then they would receive further um, diagnostic treatment and mental health intervention. Nurses who work in correctional facilities have to learn to separate from what is real and what is manipulative behavior. Um, Again, this is the same. We've had this conversation before with approaching certain types of patients. So, calm, firm, matter of fact approach is essential. Um, Prisoners must be compliant with rules and policies of the institution. Safety is always a huge, huge issue when dealing, especially with this type of group. We're going to discuss restraints a little bit. I'm going to preface this with um, you absolutely have to know what your facility policy is and in no way, shape, or form ever violate it. Restraints are a pretty serious deal. You should exhaust every other method before you ever use any kind of restraint. But if you do have to use a restraint, make sure that you're following all the guidelines set forth by your facility. What we're going to talk about are just some very general type of guidelines. So there are times when the restraints are certainly appropriate. There are three different types of restraint. Seclusion, which would be putting a person in a locked room. A lot of times ER psychiatric units have seclusion type areas. Um, Make no mistake, even though the person is not necessarily restrained within that room, they are considered restrained. They're locked in a room by themselves. And so all rules apply in this situation as far as assessing at regular intervals, safety, all of those things. There are also physical restraints of varying degrees and types, and then chemical restraints or medication administered to restrain an individual. So again, these forms are only used when verbal interventions or any kind of less restrictive method have failed and the person is at risk of harming themselves or others. A patient who's threatening to harm himself, again, can be admitted without their consent for no more than 96 hours. And again, at that point, if they need to be seen within that time period. Previous slide said 48 to 72 hours. It depends on facility, state, all of those different things. A 96-hour hold is typical, and it's what you'll probably see in this area. They do need to be seen and determined if they're competent within that time or they need to be released. While the patient is in care, they may have to be restrained, either with seclusion or restraints for a specific amount of time. Remember, those strict protocols must be adhered to. Uh, Restraints have to be reordered and signed off by the physician every 24 hours. The RN has to supervise the application There are specific intervals that restraints need to be removed. If you have a violent individual, you would never remove all of the restraints at once, but you could relieve one um, of their extremities and allow them to exercise it and move it. You always need to watch for skin breakdown, all of these things. So make sure you know what your facility policy is. Restraints should always be um, ordered for the shortest amount of time possible. Um, they are used for protection of the client. This says and the staff. I would just be very careful about that. Your that is true. I'm not going to deny it, but make sure that that's not your only motivating factor, because that could get you into some trouble. If you're protecting the client, then that will protect the staff. Um, Clients can request to be put into seclusion. There are some individuals that know that that is a safe place for them, especially somebody that is experiencing, multiple personality disorder, different hearing voices. We'll talk about all those different psychiatric issues. Sometimes they need that quiet downtime. Um, but never, ever, ever, ever is a patient restrained for convenience of staff, punishment, and our clients that are extremely physically or mentally unstable, in which the restraint could cause detriment to them. So, if somebody is being very, very violent, it might be appropriate to restrain them for their own safety. But if it causes medical harm or bodily injury, then that's a big issue. Um, for nursing, you need to, like I said, monitor safety, physical needs. They still need to eat, drink, pee, all of those things. Documentation is essential and cannot be missed even by a minute. Facilities have specific monitoring periods, either every 15 minutes or whatever the standard is. Documentation should include things like what behavior initiated restraining, what alternative actions were done first, when it was started, all vital signs, and documentation of all those basic needs being met. So feeding, toileting, giving medications. If it's not in the chart, it didn't happen. So you don't want it to look like that you did not take care of that individual, that you essentially chained them up like they did back in the day and didn't see to their basic needs. RNs take orders on restraint and overseas placement. PNs can certainly assume care of the restrained individual and do charting and observation. Like I said, it's usually every 15 minutes. Seclusion refers to placement in a controlled environment that is a restraint. And then chemical, of course, is using medications as a restraint. Somatic treatment became a big thing in the 1920s and 30s, excuse me, in hopes of curing some of issues. Fever therapy. This is just some crazy stuff that kind of happened. People were injected with malaria in hopes that they would burn out with fever, the insanity. Diabetic coma. So it was felt that coma decreased psychotic events. Yeah, sure. If you're in a coma, you quit acting crazy. That's true. People oftentimes died of this. Seizure therapy medications were given to induce seizures because you couldn't. In the treatment for schizophrenia, that's worded a little funny. People had broken bones from seizures, and all kinds of different issues occurred as a result of that. I mentioned electroshock therapy before. It worked well with depression and mood disorders, but candidates based on diagnosis were hard to get the right diagnosis. So essentially, um, we still use electroshock therapy today, but they've actually honed the treatment, and it's not as barbaric as it once was. And then, of course, lobotomy. So that's actually a surgical procedure in which the nerve fibers in the frontal lobe are severed, in people that are uncontrollably violent, or at least that was who was supposed to be receiving lobotomies. Um, about 19,000 were performed in the first year. So even people that were just acting out with different disorders that they didn't understand, they would lobotomize them. So they essentially lost all, um, they didn't have a personality anymore. They just became basically a person that sat there and stared, all the things that the frontal lobe controls our, thought processes, our personality, all those motor actions. So it's really a pretty serious thing. If you've ever seen the movie One Flew Over the Cuckoo's Nest, Jack Nicholson actually um, kind of gets himself admitted into a mental institute. Um, I guess you could say kind of for fun. He didn't necessarily need the mental treatment, but while he's there, he kind of make friends with some of the patients, and he pulls some shenanigans. And this is the movie where Nurse Ratched comes from. Ultimately, at the end of the movie, they end up lobotomizing him. It's really a horrible, horrible, horrible kind of thing. A little bit of additional historical information during World War II. In 45, there was that shift back around the 1950s, like we talked before, away from hospital and back into the community. We saw the return of war veterans that were dealing with a lot of PTSD before we understood what that really was. So the World War II was a pretty bad experience for those veterans that were returning. So, we definitely saw um, the need for increased mental health with those individuals. Um, we already talked about the National Mental Health Act being passed that gave funding for treatment of mental health. The introduction of psychotherapeutic drugs in the 60s and 70s. Thomas Sazaz wrote the myth of mental illness and argued that schizophrenia is not a disease but a reasonable adaptation to a mad world. So he might have had his own uh, maybe let's just say detachment from reality. So, Irving Goffman felt that symptoms in patients who have been in psychiatric hospitals for too long had become institutionalized, and their symptoms were caused by the institution themselves, which I think is a pretty interesting um, perspective on that. Uh, I already mentioned One Flew Over the Cuckoo's Nest being released during that time period. If It's a really good movie to watch to kind of look at mental illness and in the time period for sure. Between 1950 and 1980, inpatients went from about 500,000 to under 100,000. So that was that time period where we saw the deinstitutionalization and the closing of those services for those people. The Centers Act of 1963 and amended in 1975 improved like group homes and those types of therapy places for people that have MR, and helps return people to society and functioning in the community. In the 1980s and 90s, we saw the passing of the Americans with Disabilities Act, which helps prevent discrimination of the physically or mentally disabled person. In 1996, we saw the National Mental Parity Act, where insurance was mandated for covering of mental illness disorders. And Peplau, we talked about her in chapter 3, Hildegard Peplau, and worked to kind of advance nursing theory as it relates to mental disorder. You could read over psychotropic type medications and their use. We've talked about these in pharmacology. So, lithium is certainly still a drug that's used primarily in bipolar disorder, Thorazine, Valium, Prozac, Haldol was mentioned in the previous um, uh, slide. There's also Zyprexa and lots of different things that we use. So with the advent of drugs, it felt like people could live outside of institutions. I would say that this overall did not necessarily work because drugs alone are not enough if we don't provide support and counseling and other services. Discharged became criminals, oftentimes homeless. Drugs allowed them to function. They could hold jobs sometimes, but again, without other supportive measures, medication's never enough. You guys can read over access to care as it relates to this um, particular sect. So we've already talked a lot about stereotyping and access being huge, huge issues. Minority groups are less likely to seek treatment. Um, there are some cultural aspects, stigmas, those types of things, barriers related to socioeconomic status. According to the National Institute of Mental Health, immigrants are oftentimes affected by mental disorder. Cultural incompetence is the biggest barrier. You have to be able to talk about the patient's cultural belief to understand the perspective that they have on mental illness. There are some places, some cultural groups, like we talked about, that still believe in illness being related to uh, demon possession, the devil, punishment for wrongdoing, that person's being punished. All of these different things definitely still exist. Okay,